it's an airway issue. So the neonatologist should be made aware that this baby is getting delivered, so that that baby can be given more attention.
Hearing issue, what we should tell?
Hearing issue, we expect only if there is a significant airway, like prenatally we cannot counsel for hearing issues, and no, not at all. But yes, after birth, depending on the air, there is a restriction, recurrent infection, that may cause hearing issues, but those are rectifiable mostly. It's not going to be a sensory neural type of hearing loss which you cannot rectify. So that is just secondary to the patient this thing.
Again, thank you all for the opportunity for investigation was done or turned out homocysteine, which was moderately high, and there was vitamin D deficiency. So to correct the homocysteine, they would start on multivitamin supplements, vitamin D, along with aspirin, luteal phase support with oral progesterone, and she was asked to plan her third pregnancy, which also resulted in another missed abortion at 9 weeks, which was also medically managed. So then again, after the fourth abortion, vitamin D was rechecked, that was found to be corrected, and then they went on to investigate the beta-2 mitoglobulins and dsDNA, and karyotyping was done for both husband and wife. The wife found to have 46XX with increase in length in the one of the regions of the chromosome 9, which is also told to her that it was a normal variant and may not be the cause of a miscarriage. So again, another panel of investigation using for APLA, varicella zoster, cardiolipin, GTT was all done, all found to be within normal limits. Vitamin D was, though less, it was okay. B12 was normal, folic acid was normal, ultrasound down to only PCO and small adenomyoma, which again in the later subsequent scans that was not there. And her anti-gliadin IgA was low positive, but then again all rendomycin antibody, her methylene tetrahydrofolate reductase mutation was not detected, transglutaminase antibody was all negative. That was normal, adequate distension, regular endometrium, normal myometrial junction, and free fluid in the POD. So she was left, and male causes was investigated. Several SIM-analyses were done in different laboratories, out of which one found to have a head defect of 90%. So again, BFI was done, which is normal, by CSK 16%. Semen culture and CRP were both done, but was also normal for him. So while under this investigation, she conceived for the 4th time, and she was on a long list of medications again, with oral metformin for the PCO, oral dydrogesterone, aspirin, progesterone, low molecular weight heparin 0.4, and HCG injection. She still had a miscarriage at 9 weeks. DNA was done. Those product of conception was sent for karyotyping. That was also normal. So whole genome exome sequencing was done. That he had no problem. She was found to have positive for a carrier for autosomal recessive condition called infantile hypotonia, with psychomotor retardation characteristic phases 2, and along with another panel of investigation was done, including CD3, 19 and CD56, and all was within normal limits. Her D-dimer and fibrinogen was done. Fibrinogen was on 453, which is high, and when she conceived again, she sought Ayurvedic treatment this time, and again ended up having a miscarriage, and DNA was done, products was sent again, and they reported to be normal. Another round of APLA, panel lupus, CPC, adiocantilupe, ANA, ultrasound, VTCT were all done. It was also normal. So she had a break for 8 months. She conceived again in December 2022, and she was given including oral prednisolone, and low molecular weight heparin was increased to 0.6 ml. At 8 weeks, she had a blighted ovum, and DNA was done in Jan 2023. So to summarize, this is a young couple having 6 recurrent first trimester miscarriage. She was corrected for the hyperhomocystinemia, corrected vitamin D deficiency. Only positive here is that anti-gliadin IgA positive, and positive for an autosomal recessive condition with the raised fibrinogen level, which is again managed manageable with low molecular weight heparin and oral aspirin. And all the product of conception karyotyping was normal. So ma'am, how do we further proceed and manage this patient?
The chromosomal microarray was not done at any point of time.
No ma'am, only karyotyping was done.
So one is that in such a case where we have really done the whole workup and there's no cause. So one test which should be done is a POC, chromosomal microarray, a high resolution microarray. Why? Because sometimes some of the couples may have a translocation which is very tiny, which is below the resolution of a karyotype, and that will not come up in the couple karyotype. So that we call it as a cryptic rearrangement or a cryptic translocation. So for doing, for looking for that kind of translocation, maybe again and again giving rise to these abnormal gametes, and that may be causing these miscarriages. So if we do a POC karyotype, and that also a high resolution karyotype, which is a 750K, which is available in India as of now. So that may show up these smaller chromosomal abnormalities, and which could then, if suppose it's there, then we can do some other testing for the parents to look for the translocation, like spectral karyotyping and all. So that is one thing I would advise this couple if some sample is there still. Besides that, suppose if that also comes to be negative, which is so the yield of doing this kind of microarray in such cases is just 2%. So 98% pathogenic variant, then only there is a risk to the baby. And the risk is also of a pediatric disease, which is not a miscarriage or cause of miscarriage. So such annex mainly in the mom or something may not be there in available, or those things are not analyzed as part of a routine exome what the labs are doing, because we are looking for only conditions for which well-defined ovum phenotypes are there. So when the lab analyzes the exome report, it will look for only conditions which we know that this is the disease which happens because of this mutation. But this is an emerging area of research whereby in some studies there have been found to be certain mutations in the couple or sometimes only in the mom, which is predisposing again and again the baby to have an early embryonic demise. So it's like same like I had shown that late RPL. So late RPL, we know that many of them, once we have ruled out chromosomal abnormality, they may be having single gene diseases. But now people are focusing on the early RPL, where no cause is found despite accurate, so much comprehensive process. So some of those cases may also actually be having some single gene disorders, which we don't know as of now, for which we still need to do further studies to be able to define those cases. So I think she may probably be a candidate for such a study basically. So here, because already the exome is done, if the data is reanalyzed to look for like those studies, we can kind of review and we can see what genes people are reporting could be causing early embryonic losses, and we can reanalyze the exome data of this couple and see if they are harboring any such variants. But as I said, this is still a research field. It's clinically we may not be able to offer them a solution as of now.
Genetic. Now coming to this case, there are
points: repeated fetal expulsions and abortions. Okay. See, one in our part, this is southern coast. We are an iodine sufficient zone. So there's a lot of studies now with the iodine gene and the parathyroid gene. I'm very, very happy. In fact, I was just remarking to Dr. Vikram. Ovarian profile, Dr. Gopinath is a master. When it comes to thyroid profile, because we are in the coastal region, we are an iodine sufficient zone, we have thyroiditis playing havoc. So we have to do a antimicrosomal antibody and a anti-thyroglobulin antibody. Okay, so these two thyroid antibodies are often missed. So this is one which will indicate whether this is thyroiditis or whether it is going to be a hyperthyroid which has burnt out. See, a hyperthyroidism over 2 years period will burn out, but even if it burns out, okay, that residual activity will reflect as hormonal. Okay, I think. And as Madam had said, we have to do a DNA microarray. That is one part. And here we should not miss out the parathyroid gene, because repeatedly, in spite of correction, the vitamin D keeps going down. So that indicates, see, whenever there is a low vitamin D, then the parathormone is going to be high. So we should screen the parathormone, then a bone specific alkaline phosphatase, okay, and the parathyroid gene.
By the consultants here. The entire idea of such a genetic clinic is exactly this. How do we find out solutions for these sort of problems faced by the consultants actually? So that is where we are trying to bridge a gap actually by introducing a genetic clinic from Lifestyle's team in working in tandem with the SIMS team to ensure that every patient coming into this hospital is going out with a perfect solution actually, what to be done next actually. So we do take this opportunity to take upon this big challenge in supporting SIMS continuously from here, as Dr. Raju was mentioning that looking at the possibility, we are initiating it once in a week now, then slowly but steadily looking at the requirement, maybe on a regular basis, looking at the patient flow. Lifestyle is definitely ready to support SIMS on the need of such a situation also, because we do have the manpower strength also to handle such scenarios. So that assurance also we are providing it from Lifestyle end actually. And would like to thank our chief guest actually, Dr. Shagun Agarwal. Yes, we are always happy to have such stalwarts coming to such clinics and inaugurating and sharing their expertise. Yes, stalwarts like Dr. Ashwin Dalal, Dr. Shagun Agarwal, who are always pioneering into their segment. So we do really thank Dr. Shagun Agarwal for taking the pain to come out from Hyderabad for a single day to inaugurating this clinic and presenting and giving us a lot more information on what is this field of genetics actually. So thank you madam for coming out here for this function. Definitely Dr. Raju Shivaswamy, who is the Vice President of SIMS. Yes, we do thank you for your esteemed presence here. Then Dr. P.M. Govinathan sir actually, of obstetric and gynecology department. I was just interacting with him, a lot of known doctors that his disciples actually. Definitely thanks Dr. Govinath also. Yes, we have been working in tandem with Dr. Vikram also. So thank you Dr. Vikram and all the other consultants of this and the admin team of SIMS Hospital and all the media persons plus all the dignitaries who have come and attended this function. Thank you all.
செயல்பாட்டுக்கு ஒரு குரோமோசோம் காரணம். அந்த குரோமோசோம் அதாவது இருக்க வேண்டிய இடத்துல இருந்திருந்தா ஒழுங்காக வேலை செய்யும். ஏதாவது ஒரு இடத்துல ஒரு பொசிஷன் மாறிடுச்சு இல்லை டெலீட் ஆகிடுச்சுன்னா அவங்களோட பிஹேவியரே மாறி இருக்கும். அதனால மொத்த ஃபேமிலியும் அஃபெக்ட் ஆகிறாங்க. இதை கண்டுபிடிச்சு இந்த மாதிரி ஜெனடிக் கிளினிக்னு ஒரு நியூ கான்செப்ட். இது ஒவ்வொரு லெவலையும் ஒரு மைக்ரோ லெவலில் எப்படி வந்து இப்போ டெக்னாலஜி மாறி ஒவ்வொரு டெக்னாலஜியும் மைக்ரோ லெவலில் போதும். அது மாதிரி நம்மளாம் அந்த காலத்தில் ஃபோன் பேசும், பெரிய ஃபோனில் பேசுறீங்க, இப்போ செல்ஃபோனு, இப்போ சின்ன மினி ஃபோன் வரைக்கும் வந்துடுச்சு. அது மாதிரி நம்மளோட ஜெனட்டிக் ஸ்டடியும் வந்து நிறைய ஸ்டடி போயிட்டே இருக்குது. இந்த அட்வான்ஸ் ஸ்டடிக்கு வந்து டார்கெட்டட் தெரப்பி, இப்போ கேன்சர்லாம் வந்து டார்கெட்டட் தெரப்பியும் கொண்டாட்டாங்க. எந்த ஜீன் அஃபெக்ட் ஆகுதோ அதுக்கு தகுந்த மாதிரி டார்கெட் தெரப்பி. அதை இப்போ மேடம் சொன்னாங்க. இந்த மாதிரி நம்ம கண்டுபிடிச்சதுக்கப்புறம் அதை இன்டெப்த்தாக அனலைஸ் பண்ணும்போது வந்து என்ன ட்ரீட்மெண்ட் கொடுக்க முடியும், இது ஆன்டிபாடிஸ் ரெஸ்பாண்ட் பண்ணுமா பண்ணாதான். அப்போ ஃபஸ்ட் ட்ரைமஸ்டரில் இந்த அபார்ஷன் பண்ணிங்கன்னா அந்த குழந்தைய வெளில பண்ணாந்து மொத்த குடும்பம் கஷ்டப்படுவாங்க. அது வேண்டாம்னு சொல்லிட்டு அதுக்கான ஆப்ஷன் இருக்குது. ஐவிஎஃப்ல எப்படி போகலாம், இதெல்லாம் வந்து ரிசர்ச் பண்ணி கொண்டுட்டு வந்திருக்காங்க. இதை வந்து மக்களுக்கெல்லாம் கொண்டு போய் சேர்க்க வேண்டியது எங்களுடைய எய்மு. அதை வந்து டாக்டர் ஷானோகள் வந்து டீட்டெயில்டாக பேசினாங்க என்னென்னலாம் ஸ்டடி பண்ண முடியும்னு. இதை மக்களுக்கு கொண்டு சேர்க்கணும்னு நம்புகிறோம். தேங்க்யூ. அப்படி அவங்க
இது டைரக்டர் ஆஃப் ஆப்ஸ்டெடிக்ஸ் அண்ட் கைனகாலஜி அண்ட் ஐவிஎஃப் SIMS ஹாஸ்பிட்டல். இதுல ரொம்ப இம்பார்ட்டன்ட் ஆஸ்பெக்ட்ஸ் என்னன்னு கேட்டீங்கன்னா, இது வந்து நாங்க கம்ப்ளீட்டா ஃப்ரீயா பண்றோம். இந்த ஜெனடிக் கிளினிக் வந்து we are not charging, it's completely free. வரவங்களுக்கெல்லாம் பார்த்து டீட்டெயிலாக அனலைஸ் பண்ணிட்டு என்ன சொல்யூஷன்ஸ் கொடுக்குறோன்றது இட்ஸ் கோயிங் டு பி டன் ஹியர். ஒரு இன்ஃபர்டிலிட்டி ஆகட்டும், இல்லை திருப்பி ரிப்பீட்டடாக குழந்தைக்கு ஒரு அபார்ஷன் ஆகுது, இல்லை ஏதாவது ஒரு அப்நார்மல் பேபி ஃபர்ஸ்ட் இருந்ததுன்னா அவங்களெல்லாம் கூப்பிட்டு வந்து ஒரு வாரத்தில் ஒரு நாள் நம்மளோட டார்கெட் பண்ணி வச்சுருக்கோம், ஒரு ஃப்ரைடே அன்னைக்கு. ஸோ திஸ் கம்ப்ளீட்லி இட் இஸ் அ ஃப்ரீ சர்வீஸ் டு த கம்யூனிட்டி. இது வந்து நீங்கள் ஐ திங்க் எல்லாரோடையும் நீங்கள் போய் சேர்த்து எல்லாருக்கும் பயனடைய செய்கிறது உங்களோட முக்கியமான மெட்ராஸ்ல ஒரு மல்டி ஸ்பெஷாலிட்டி ஹாஸ்பிட்டல்ல this is the first time the clinical genetic service. The cost ன்னு சொல்லமா இது இன்ஃப்ராஸ்ட்ரக்சர் பிரெயின் அண்ட் பென் தான். ஸோ படிச்சவங்க இவங்க மாதிரி ஒரு இதுல இருந்து வச்சு அனலைஸ் பண்ணி என்னன்னு பார்க்க போறோம். அந்த டெஸ்டிங் எல்லாம் இருக்கிறது மேடம் சொன்ன மாதிரி ஒரு ஆர்டினரி குரோமோசோமல் டெஸ்ட் இருக்கு, அதுக்கு அடுத்தது வந்து என்ஜிஎஸ் ஸ்கிரீனிங் இருக்கு, அப்புறம் மைக்ரோ அரே டெஸ்டிங் இருக்கு. அது போக போக அந்த காஸ்ட் எல்லாம் வந்து கம்ப்ளீட்லி டிஃப்ரெண்ட். நாங்க அது பண்ற போறது இல்லை, நம்ம அனலைஸ் பண்ணி என்ன டெஸ்ட் பண்ணணும்னு பண்ணி அவங்கள அனுப்புவோம்.
I'm Dr. Shaguna Devan. I'm additional professor in Hyderabad. So I congratulate the SRM Institute for this wonderful initiative. So at present in India, there are only around 8 to 9 centers who have this facility whereby patients can undergo genetic evaluation. They will be seen by a specialist who is super specialized in field of clinical genetics, and then following which there are different tests as sir mentioned. So beginning from small basic level genetic tests, now we have technological advancements whereby we can do very high level of genetic tests. So all these facilities as of now in India, very few centers are there, and now in Chennai this is the first multi-speciality hospital which is starting this clinic, and it is indeed a very kind of a very big advancement, and I'm sure that it would be very useful for all the patients. Many of these patients who have genetic diseases, because we don't have the specialized doctors in our country, they are never able to make a diagnosis for these patients, and they will keep on going from one doctor to another doctor, and nobody is able to understand what is their problem actually. And often in such cases in that family, again next baby may also have the same problem. So it will run in generations, or many more children can have the same problem. So it is very important to have such genetic clinics so that these families who don't have any answer in the current medical system, where they are not able to find a diagnosis, we are able to diagnose their conditions, and then now we are also able to make some treatments which are specific for that particular patient. So that's why this is really which is something which is very much needed at present, not only in Chennai. In fact, it needs to spread all across India, and we need to have many more centers like this.
Sir,